So hydrocortisone. So this is referenced with shared health medication profile M13 and E03 anaphylaxis. So hydrocortisone, like I said, referenced in E03 anaphylaxis and is to be used if a patient is in refractory anaphylaxis with no improvement after 3 doses of epinephrine. It's very specific to that, so we're going to try and go along with those guidelines here. And you can use it as well as if your transport time is greater than 60 minutes with an anaphylactic patient. So looking at the actual care map here, epinephrine is always our first line treatment of anaphylaxis. So as per our care map here, no matter what your scope of practice is, you always want to use epinephrine as your first go-to medication. So with that as well, when we look down the care map here, we don't actually access hydrocortisone until we're dealing with refractory anaphylaxis, which I'm going to talk a little bit more about in a minute about what that actually means. Whenever we give a medication, the colored boxes are being currently phased out as we update our care maps. So when we're looking at giving a medication, always reference the care map as the guide to giving a med. But when it comes to actually what you're allowed to give as per your scope of work, reference the medication profiles. Care map guides you to a med, go to the medication profile to see if it is within your scope of work to administer. So when it comes to anaphylaxis, there's 4 types that are recognized. We have uniphasic, protracted, biphasic, and refractory. So obviously refractory is what this care map guides to, but we're going to talk about all the different types as well. So we have uniphasic anaphylaxis. This is the most common type of anaphylaxis, which we're going to probably see in EMS. So this is people with the swollen throat, can't breathe, hives, itchy. So again, what we're taught from first aid class and up, this is the most common kind. This kind of anaphylaxis actually creates about 80 to 94% of all the episodes of anaphylaxis that we're going to see. So with this as well, with uniphasic anaphylaxis, someone gets exposed to an allergen, they have a reaction, it either goes away on its own or we intervene medically and then it's resolved. It doesn't have continuing issues after that. Then we have protracted anaphylaxis. So this is a persistent anaphylactic reaction that lasts hours to days without completely resolving. It's not very common. And to actually be diagnosed, they have to have symptoms for at least 4 hours. So what this can mean is that we give therapy. We may resolve a lot of the issues, but they're not totally gone. So these are kind of like your patients that you give epinephrine, their breathing's good, but they've still got lots of itchy hives and a little bit of swelling elsewhere in the body. And if it just keeps going on, even though we're treating it, then it's considered protracted anaphylaxis. Next one is biphasic anaphylaxis. This is more common than protracted anaphylaxis, and this can happen in both adults and children equally. It's not to one specific age demographic. And biphasic anaphylaxis is characterized by initial reaction that meets criteria for anaphylaxis followed by asymptomatic period for 1 hour or more. So with that, spontaneous return of symptoms, meaning criteria for anaphylaxis without further exposure to antigen. So they're going to have their initial allergic reaction. We're going to get there. We're going to give them epinephrine. Everything's great. And then about 45 minutes, an hour later, or just whatever time period it is, all of a sudden, without being exposed to it again, they'll start having an anaphylactic reaction. So let's use an example of someone gets stung by a wasp. They go into anaphylactic shock. We deal with it appropriately. We're transporting them to the hospital. They didn't get stung again. Then all of a sudden, an hour later, they start having the same reaction, even though they haven't been reintroduced to that allergen. So it's been reported to happen with many different forms of allergen. The most common ones that people have these reactions to are ingested because it's still in their system, injected, and IV administered solutions. So people that have bad reactions to medications through the IVs can suffer from biphasic anaphylaxis. And to be defined as biphasic anaphylaxis, the time between first onset of anaphylaxis, the start of second, usually it's an hour or so, that it can last up to a couple of days. So sometimes you have those patients that you treated today, they start at the hospital, the next day you get called back because they're having a biphasic anaphylactic reaction. And sometimes people can just have these. Like again, 2 days later, you're not exposed to that wasp sting and you're having a reaction again. So that is very possible. So the big one here is refractory anaphylaxis. That's what it guides us to in our care map. So it's defined as continued symptoms of anaphylaxis despite appropriate epinephrine dosing and symptom-directed therapy. So when we talk about symptom-directed therapy, so we gave our initial dose of epinephrine as our emergency first go-to, which is what we're always recommended first. But then we also give our fluid boluses and our salbutamol, and we've been doing all that therapy, and it's just not working. Okay, they're still having those symptoms of anaphylaxis. So For what we're doing, the term is applied to reactions that have been treated with 3 doses of epinephrine or initiation of epinephrine infusion. So basically what we're doing with, because we're not going to start an epinephrine infusion, that's more so in the hospital. If we've given patient 3 doses of epinephrine and we're finding that they're not getting the results that we desire, then we can consider them in refractory anaphylaxis, and we can access this care map to give hydrocortisone. So what is hydrocortisone? It's a therapeutic. Hydrocortisone is a synthetic or semi-synthetic equivalent of natural hydrocortisone produced in the body. It's produced in your adrenal cortex. It's also known as cortisol, and it's commonly used in anaphylaxis to attempt to prevent protracted symptoms, so that, again, if we're giving epi, we're only sort of resolving the symptoms. And it's also used to prevent biphasic reactions, or it's, for example, with ours, we're using it for refractory anaphylaxis. So with hydrocortisone, I don't have a degree in microbiology, so I can't go into depth of all the actual what happens in the cells here, but I'm going to put it in a nutshell here. So we give hydrocortisone, it binds to intracellular glucocorticoid receptors and suppresses inflammatory immune responses. So it affects numerous steps in the inflammatory pathway inside the actual physical cell. So the steroid molecule, so the hydrocortisone, diffuses across cell membranes and binds to glucocorticoid receptors, which causes a uniformal change inside the receptors in the cell. Once it's inside the cell, it starts reactions that results in RNA or ribonucleic acid and protein synthesis, which controls synthesis of pro-inflammatory mediators. So long story short, the steroid goes into the cell and helps to prevent the triggering of the inflammation response that is created in the actual individual cell. So when we look at M13, so that's the actual medication profile we're going to reference to when we talk about hydrocortisone, we always want to reference our scope of work. So as per M13 for shared health, providers with the EMR and PCP scope of work may not administer hydrocortisone, even directed by a physician. It's very important that we stick within our scope of work. So if you get orders from a physician in an ER and you're a PCP and they want you to start administering hydrocortisone, we can have to tell them, no, it's outside of my scope of work. However, if you have an ICP or higher scope of work, you may administer hydrocortisone as outlined in the medication profile or with order from an ERS affiliated physician. So again, in the care map, it says that this medication is for refractory anaphylaxis. But as we learned, there's different types of anaphylaxis that can cause secondary reactions. So we can call online medical support and request it for that reason as well and get orders from a physician to give it if we think it's beneficial for our patient. So when do we give it? So as per the care map, we want to give it for refractory anaphylaxis, or if we look at a transport time greater than 60 minutes for an anaphylactic patient. The M13 document hydrocortisone also discusses giving hydrocortisone for adrenal insufficiency. We do not have a care map for adrenal insufficiency right now, so I'm going to leave that alone in this presentation and just focus on anaphylactic use of hydrocortisone. So for contraindications, there's actually none as per our care map. Hydrocortisone itself for long-term use does have a lot of side effects and cause a lot of issues, but for what we're doing in EMS for our one-time emergent dose, there's no contraindications. There are side effects, however, for giving this medication. So the most notable ones would be ataxia. So basically, it could affect coordination, balance, and speech. It can cause behavioral changes, dizziness. Patient could experience euphoria, fatigue, headache, and malaise. You can cause syncopal episodes, but again, that's usually with multiple doses, not very much in one. And with any other medications, they can have a bad reaction and have nausea, vomiting. A big thing to keep in mind that with side effects of this medication as well is it can cause cardiac dysrhythmias, and it can cause your patient to become bradycardic. So if you're going to give this to your patient, if you don't have them on the monitor already, I would recommend putting them on the cardiac monitor if you're giving hydrocortisone. Interesting side effect of hydrocortisone as well is it causes hiccups. So if you're driving your patient to the hospital and they start hiccuping for the last 30 minutes of your ride, it's because of hydrocortisone. So when we give our hydrocortisone, it's given intravenous, and basically for all ages, it's 5 milligrams per kilogram. It's a weight-based dose. We max out at 400 milligrams for each patient, and it's a one-time dose. We don't give multiple times unless directed by a physician. So some general instructions we give it. We want to infuse it over 2 minutes. It is caustic to the veins, so it can cause discomfort when you're actually putting it into your patient through the IV. So it's recommended that you give it as a slow push. You don't just ram it into your patient. Okay. It can be given IV or IO, and it has a pretty rapid onset of action, and it can start within an hour. So usually it's around an hour for it to reach its full peak effect. So this is a big reason why I want to do this presentation here. Hydrocortisone is actually provided in a 500 milligram Mixo Vial. This is the first time we've had one of these in the ambulance that I'm aware of. So this is how it's going to be provided. This picture actually came straight from our pharmacy department of what they're going to be providing us with for hydrocortisone. So with the Mixo Vial, it's got different parts here. So we have a plastic tab at the top. We have a plastic cap at the top. It actually has water that is separated by a rubber divider from the actual powder medication. So very similar to glucagon, we're going to have to reconstitute this medication. So to use the Mixo Vial, we want to mix the medication in the vial. So as I said before, there's liquid in the top section and powder in the bottom section. So what we want to do is, and you can do it however you want, you need to push the top down so that the liquid gets pushed into the bottom and mixes with the powder. So however you want to just push it down, just don't crush the vial. So that way the water gets pushed into the medication. So once you've got the water into the medication, you want to gently mix the solution without shaking it. And you can turn the vial upside down, but just like glucagon, you don't want to shake it. You don't want to cause that. You just want to mix it gently together. Okay. So you can do that however you want. So just upside down and back. When you initially mix it, the solution will be cloudy. That's normal. It will turn clear, so you're all good. So the next step would be to remove the plastic tab covering the stopper at the top of the vial. So you take that off and that exposes the rubber stopper that you're actually going to draw your medication out. It's recommended that once you've taken off that plastic tab covering the stopper, that you swab it with an alcohol swab to make sure there's no debris or anything left there after you took the plastic tab off. Next thing you do is, just like any other vial now, we just insert our syringe in. We put our needle through the rubber stopper and we withdraw the correct dose as per our guidelines. And as I said before, we want to make sure we're giving our medication over 2 minutes. It's a slow push, and that's it. So that's all I've got. I just like to keep these presentations short, so that way it doesn't take a half hour to talk about medication. So does anybody have any questions at all?